Now I'd like to welcome and introduce our presenter. Alexis Chettiar is an acute care nurse practitioner for the East Bay Nephrology Medical Group in Oakland, California, and is currently earning her PhD in health policy at the University of California, San Francisco. She serves on a technical expert panel for the Centers for Medicare and Medicaid Services, which is developing quality measures for emergency department utilization by end-stage renal disease patients. Alexis also serves on the National Kidney Foundation's Chronic Kidney Disease Payment Reform Committee, and the NKF is also one of our sponsors today. She sits on their steering committee for a randomized clinical trial on care delivery system efficacy in forestalling progression of chronic kidney disease. Alexis has also authored several publications and presents regularly on the topic of chronic kidney disease. So please join Johnson & Johnson and the National Kidney Foundation and welcome Alexis. Alexis, welcome, and the floor is yours.
Great. Thank you very much, Mary. I'd like to thank also NKF and Johnson & Johnson for inviting me to speak today. Let me get through to the slides here. So it looks like we have a mix of providers and working in both inpatient and outpatient settings here. That's helpful for me to know so that I can tailor the content here such that it's most relevant for your particular practice settings. So I'd like to start by setting the landscape in nephrology care in the United States. And in nephrology, we talk about the CKD pyramid. So that CKD is chronic kidney disease. And if you think about a pyramid with CKD 5 being at the top and CKD 1 being at the bottom, that gives you some sense of the distribution of the volume of CKD patients in the United States. And what that means is that CKD 4 and 5, which is generally who's being seen by a nephrologist, is a very small proportion of the total number of CKD patients. And in fact, the overwhelming majority of CKD patients in the United States are CKD patients with stage 1, 2, or 3 chronic kidney disease. And those patients are generally cared for by primary care providers and other non-nephrology providers. And so there's growing awareness within the nephrology community that if we really want to change the course of chronic kidney disease care, we need to be proactive in our outreach to non-nephrology providers and talking about how to ideally manage chronic kidney disease before it gets to the stage where patients are seeing nephrology providers. And so what we're doing today is part of that effort, and I really want to thank all of you for investing the time and participating in this session. We know that early diagnosis of CK makes a difference. It changes provider behavior. In this era of clinical pathways, it tends to route patients into receipt of services that they might not otherwise. That includes both therapeutic agents and support services, so counseling, education. Early detection of CKD, it improves management and provides demonstrable improvement in patient outcome. And CKD truly is a part of primary care. Let's talk a little bit about CKD risk factors. I think that the categorization of modifiable and non-modifiable could be disputed, but really the intent here is to put patients on your radar. So who should you be thinking about or concerned about in terms of a CKD diagnosis? If you look under the modifiable category, you'll see number 1, diabetes and hypertension. Number 2, those are the number 2 most common causes of end-stage renal disease in the United States in that order. Acute kidney injury can both precipitate chronic kidney disease and accelerate progression of established chronic kidney disease. And the same is true for NSAID use, that's non-steroidal anti-inflammatory drug use. Non-modifiable risk factors include family history of kidney disease, diabetes, or hypertension. We also know that GFR, which is our measurement of kidney function, we'll talk a little bit more about that in the subsequent slides, but we know that kidney function normally declines with age. And so what we see is that after about the age of 40, patients normally lose about 1 milliliter per minute of kidney function per year. And so when you're evaluating elderly patients, you want to keep that in mind and make sure that you really understand whether what you're seeing is true to CKD or normal age-related changes. And race has an impact on muscle mass, which affects the way that we interpret the serum creatinine. So again, we'll talk about that a little bit more in the upcoming slides. So diagnosing CKD, as we just mentioned, it changes provider behavior. It makes providers more likely to check for protein in the urine, which is a urinary albumin testing. This is a really key element of understanding a patient's risk for chronic kidney disease progression, in addition to their cardiovascular morbidity and mortality risk. It increases the appropriate use of ACE and ARB therapy, so that would be ACE inhibitors or ARBs. These are two classes of blood pressure medications that are really valuable in treating diabetic kidney disease. They can slow progression and reduce the incidence of micro and macrovascular complications. Providers are more likely to avoid iatrogenic insult if patients carry a diagnosis of CKD, so that includes NSAIDs as well as other potential insults. Patients are more likely to be referred appropriately for nephrology consultation if they carry a CKD diagnosis. And what we see in some of the larger data trials is that a CKD diagnosis does, in fact, provide tangible improvement for patients with early stage CKD. So that would be patients with CKD stage 1, 2, or 3. And currently what we see in terms of patterns of diagnosis is that CKD 1 and 2 is very, very rarely diagnosed. And there's a real missed opportunity there, meaning that we could be intervening earlier in the stages of chronic kidney disease when kidney disease is actually more amenable to change in course than later in the disease process when much of that damage is already established and irreversible. So let's talk about how we diagnose kidney disease, and there are two central elements to that. The first is the measurement of the kidney's capacity for filtration. So we describe that as eGFR. E is for estimated, G is glomerular filtration rate, FR. And so what we're looking at is how well the kidneys are removing creatinine from the bloodstream. And just as a quick review, creatinine is a byproduct of muscle metabolism or protein metabolism, the majority of which is from muscle metabolism. And so creatinine normally varies based upon muscle mass. So we see a difference in creatinine based upon age, sex, and body mass because all of those affect the patient's muscle mass. And when you see a rise in serum creatinine, what that tells you is that the patient is not, the kidneys are not adequately clearing that metabolite from the serum, and as a result, you have the higher serum creatinine. So it's important to know that because muscle mass varies, as expected, based upon these factors, age, sex, and body mass, that the serum creatinine is different. There's a different normal for each person depending upon sort of where they are with age, sex, and body mass. As a result, serum creatinine is really not the best way to assess kidney function. What we do is we use that, we incorporate it into a formula that also adjusts for age, sex, body mass, and race, and that gives you an estimated GFR. So you can think about the eGFR as being roughly comparable to percent kidney function. So normal GFR would be between 90 and 110. So it's not a perfect comparison, but I think it's helpful just in terms of putting the interpretation in perspective, both for us as providers and also for patients when you're offering patient education. So these days, the tool used most commonly for estimating GFR from creatinine and these other factors is the CKD Epi tool. That's really considered to be the superior tool. There are a couple of other older calculators out there. They're not commonly used. It's really the CKD Epi that we should be using. One thing that's important to know about the CKD Epi is that it doesn't adjust for differences in body mass. It assumes that every patient has a body mass of 1.73 meters squared. So that's sort of about an average-sized person. However, that means that it will misestimate the GFR for people who are very large or very small. So there's actually a manual, sort of a secondary adjustment that you can do, and we'll talk a little bit more about that in the next slide. But so assuming that we've generated an eGFR for a patient, and this is oftentimes reported in a lab result in addition to the creatinine, let's take a look at how we would interpret that. And if you look at the box at the bottom of the slide, it describes the staging of kidney disease. So CKD stage 1 would be a patient who has normal kidney function, preserved renal function, but has some structural abnormality. So that would be a patient who might have polycystic kidney disease or some other hereditary kidney disease. There hasn't been any effect yet on the filtration capacity of the kidney. However, they do carry the diagnosis of CKD stage 1 as a result of their structural abnormalities. Stage 2 would be a GFR of 60 to 90, so slight reduction. I would say that, as we discussed, the missed opportunity for making a diagnosis of CKD2, it's pretty rare in clinical practice to see somebody carry a diagnosis of CKD2. I think oftentimes providers don't consider this to be an alarming enough finding to even note necessarily. But as you'll see later when we talk about protein in the urine, even stage 2 CKD, if conjoined with abnormal protein in the urine, can really be a very negative prognostic indicator. And, I would, again, just emphasize the fact that we're going way upstream in the disease process, but this is also really our best opportunity to intervene. I work with a nephrology practice. By the time I see patients when they have CKD 4 and 5, done is done for the most part. At that point, we're preparing for dialysis or medical management of kidney failure, or whatever the choice has been made. But there's very limited opportunity to change the course of that disease process, whereas when you're seeing a patient so far, so much earlier in their disease process, there's really a lot more that you can do in terms of forestalling CKD progression. Anyway, so going on to CKD stage 3, and that would be for GFR between 30 and 60. Clinically, we divide this into stage 3A and 3B. So stage 3A would be 45 to 60. That's the earlier stage 3. And then 3B, latter stage 3, that would be 30 to 45. And then stage 4, 15 to 30. Stage 4 is where a patient would typically come and see a nephrology provider. At this point, you may start to see more overt manifestations of kidney disease, more dysregulation of electrolytes, anemia, other things that require more specialized and intensive management. And then stage 5 is described as kidney failure. That's a GFR of 15 or less. And patients typically start dialysis when their kidney function is somewhere in the range of 10%, or GFR is about 10. Again, that varies by individual, but somewhere in that range. So the intent of this chart here is to describe the difference in actual kidney function relative to a serum creatinine. So if you take a look here, what you'll see is that all of these patients have a serum creatinine of 1.6. So let's look first at that top row, though. So that would be a patient profile. He's a 25-year-old African-American male, larger guy, 285. So he has substantial muscle mass. We're going to say that this is a very athletic patient. And what you see when we use the CKD epi formula to estimate his GFR from his creatinine, we get a result of 68, which would say that he has CKD stage 2. When we adjust that for his body surface area, because he's a very large person, we see that in fact he has normal he has normal renal clearance. He has normal kidney function. We would still need to make sure his blood pressure is okay, check for protein in the urine. But what we can see is that in his case, because he's large, young, African American, big muscle mass, a serum creatinine of 1.6 is essentially demonstrative of normal kidney function. If we skip down to the last row, this is an elderly female, 92 years old, 98 pounds, very small person, creatinine of 1.6. CKD epi estimates her GFR to be about 28. She's in CKD 4, even with that estimate. When you further adjust for her small size, you see that her GFR is 22, meaning that she's actually getting pretty close to CKD stage 5, the point at which you're really anticipating that she either might need medical management or dialysis for treatment of her kidney failure. So this is to illustrate the fact that creatinine is really not an ideal way to estimate kidney function, that it needs to be interpreted in the context of these other factors based on the CKD epi equation with further adjustment for the body surface area in the case of patients who are very large or very small. So let's talk a little bit here about the second leg of our diagnosis here. So we had talked about the filtration capacity. Now we're going to talk about screening for protein in the urine. So we talk about an albumin to creatinine ratio, ACR, and that's checked with a spot urine. It should be collected first thing in the morning, but that's not absolutely crucial. It's a really easy test to order, easy for the patient to complete. They just need to submit a lab sample, a urine sample. Historically, we used to assess protein in the urine with the use of a 24-hour proteinuria test. That's very rarely used these days, and I would make the case that although technically the 24-hour measure of protein is the better test because it's a direct measurement, it's highly fallible in terms of patient collection. The likelihood of a patient accurately following instructions such that we actually see urine that is the true 24-hour volume is pretty low. So anyway, in clinical practice, we rarely use that these days. Generally speaking, we'll check it just with the spot ACR. Criteria for CKD diagnosis. Now, assuming that we've checked the GFR, we've checked the ACR, we had this information available to us, how are we going to interpret that in terms of a diagnostic finding? So if a patient has structural abnormalities, we talked about them having CKD stage 1, that qualifies them for a diagnosis. If they have either protein in the urine and or reduced filtration capacity for greater than or equal to 3 months, they are eligible for a diagnosis of chronic kidney disease. And the staging would depend upon how compromised their GFR is, how low it is. And I find this last bullet point to be a fairly stunning statistic. We live in this era of big data analytics, and so particularly insurance providers can actually evaluate some of these metrics. And what was done to generate this information was analysis of patient records and then comparison. So among diabetic patients who satisfy lab criteria for CKD, whether that be protein in the urea and or reduced filtration capacity, how many carried a diagnosis of chronic kidney disease, and it was only 12%, which I just find to be stunning given the fact that there are guidelines for routinely assessing patients with diabetes for chronic kidney disease, and given what we know about CKD and its health implications. So I suspect that the majority of these patients fell in the CKD stage 2 category. Again, it's rare that providers at that stage, as we heard from the question recently during the polling session, even with a GFR of 45, so further compromised kidney function, that patient still wasn't aware she had CKD. I think it's much rarer still for providers to make a formal diagnosis and convey that to the patient at CKD stage 2, but that's truly, truly a missed opportunity. So I hope you'll remember that as a take-home point from today, that we really need to be diagnosing and intervening earlier in our CKD patients. This is a heat map, and it's a great tool to help understand the implications of proteinuria. So if you look on the left side, you'll see the stages G1 down to G5, and those correspond with the CKD stages that we've talked about. So, and then if you look at the top, the A1 to A3, that's describing the level of proteinuria. So let's take, for example, G2. So that would be the stage 2 kidney disease that we just talked about. And you can see as you look across that line how much that patient's risk profile differs based upon the amount of protein in the urine. So even though the degree of reduction in their filtration capacity is pretty minimal at CKD stage 2, we can still see that if they have a substantial amount of proteinuria, that they are at moderate to high risk for both progression of chronic kidney disease and cardiovascular morbidity and mortality, which closely mirrors the CKD progression risk. One further thing that I would bring your attention to here is the amount of proteinuria that we're talking about. So if you look at that A3 category, they're talking about greater than 300 milligrams of proteinuria per 24 hours. You know, diabetics routinely will spill a gram or more of proteinuria, and patients with other types of kidney disease sometimes will spill 10 or 12 or, even up to 20 grams of protein per day in the urine. We're talking here about only 300 milligrams of protein in the urine being adequate to substantially increase the patient's risk both for CKD progression and for some of the other comorbid, the cardiovascular risk profile. This helps to really illustrate why it's so important both that we're screening for protein in the urine and that we're treating that as part of our management of chronic kidney disease. So this chart describes the difference between ideal and actual CKD progression. If you look at the top line, that describes sort of the baseline rate of GFR loss associated with chronic kidney disease. So there's a certain degree of disease progression that is not amenable to medical therapy, meaning that it will happen essentially irrespective of a delivery of ideal therapy. However, when you look at the bottom line, this describes a more actual clinical pathway for patients. So you see your patient has a baseline CKD, but fairly well-preserved renal function. They may not yet be carrying a diagnosis of CKD. They have a gout flare, NSAIDs are recommended. They have an episode of acute kidney injury, worsens their baseline renal function. They present to the ER with chest pain. They are admitted for, say, a PCA. They get a big dye load in that coronary cath, further reducing their kidney function. Later down the road, they're treated with a course of antibiotics. It happens to be a nephrotoxic aminoglycoside, further reduction in their kidney function. At this stage, because their kidney disease has been accelerated, maybe they're having issues with hypervolemia. They're likely on an ACE or ARB. They're also treated with a diuretic. And they may have an episode of, say, dehydration related to gastroenteritis. And, now we've precipitated more accelerated worsening of their chronic kidney disease or underlying chronic kidney disease. Unfortunately, this is all too common, this iatrogenic acceleration of chronic kidney disease, and it's a real opportunity for us to improve our management strategies such that we help patients be closer to that upper line, that ideal progression. A couple of other things to think about when you're caring for CKD patients in terms of their patient safety. We certainly want to avoid intravenous contrast dye. We also want to avoid gadolinium-based contrast that can precipitate nephrogenic systemic fibrosis. It's rare but terrible. I think this is less well known that patients with chronic kidney disease should avoid sodium phosphate bowel preps. The phosphate can actually precipitate in the renal tubules, causing sort of an accumulation of sludge. It's almost similar to the pathology in in a rhabdomyolysis syndrome. So that can precipitate both acute kidney injury and worsening of chronic kidney disease. We want to be really attentive to their cardiovascular disease risk profile. Very important given what we know about the risk introduced both by chronic kidney disease, but also the fact that people in this population very frequently suffer from metabolic syndrome, which means that their risk factors have a multiplicative effect. And then, as we had referred to in the previous slide, in the earlier stages of CKD, we really want to be careful not to precipitate acute kidney injury through either low blood pressure or low blood volume. And so these are patients who tend to have a rather fragile volume status and want to be really careful to educate them, certainly if they're on an ACE or an ARB, that they need to stop that if there is any suspicion of hypotension or hypovolemia. We'll talk a little bit more about that later. And later in the stages of CKD, they're more at risk for volume overload, CHF exacerbation. So this is a list of reasons that you might refer to a nephrology provider. Certainly if a patient has acute kidney injury or if they fall into that CKD 4 or 5 stage we were talking about. If their urinary protein is persistently above that 300 milligrams per 24-hour range, they really should see a nephrologist for assistance with management. The nephrologist may have more tools in their toolkit in terms of suppressing the proteinuria, and that really does make a big difference in terms of their longer-term risk for CKD progression. I want to bring to your attention this idea of atypical progression of CKD. We're talking today about diabetic kidney disease, and one of the things that I've observed in clinical practice is that providers can be lulled into complacency when it comes to assuming that any diabetic with kidney disease has diabetic kidney disease. The risk for non-diabetic kidney disease among diabetics is the same as among any other population. So diabetics are still at risk for IgA nephropathy, for post-infectious nephropathy. And while it's true that most of your diabetics with CKD will have diabetic kidney disease, that's not true of all patients. And if you're alert to differences in the clinical presentation, typically that will be apparent. But I just would encourage you to really pay close attention and make sure that you follow up and refer appropriately any patients who don't fit a typical diabetic chronic kidney disease profile. If you're having a hard time managing blood pressure, that would be a good reason to refer to a nephrologist, certainly if they're on 4 or more antihypertensive agents. If patients have persistently high potassium, or if they have extensive kidney stones or hereditary kidney disease, those would be good reasons to see a nephrologist. Let's talk a little bit about blood pressure regulation and CKD progression. The take-home point here really is that it is more important to achieve goal than what agents you achieve that goal with. The caveat there being that if you're treating diabetics with protein in the urine, they really should be on an ACE or an ARB. We'll talk a little bit more in a further slide about what the goals would be, but generally speaking, for diabetics with kidney disease, unless they're intolerant, you really do want to think about managing with an ACE or an ARB. And I would go so far as to say, although this isn't reflected in the guidelines, that if a patient with diabetes has diabetic kidney disease, even if they don't have proteinuria, it probably makes sense to start them on an ACE or ARB. And the reason being that proteinuria is a hallmark diagnostic feature of diabetic kidney disease. And when I see a diabetic patient without proteinuria, I think of them as being not non-proteinuric, but pre-proteinuric, meaning that in all likelihood they will develop protein in the urine, even if it's at a low level, and therefore will benefit from an ACE or ARB as part of their antihypertensive regimen. Certainly if it's a non-diabetic patient with CKD, the choices are a little bit more open, and ACE or ARB is okay to use in that context as well. So assuming you've started your patient on an ACE or an ARB, a couple of things that are important here. You want to make sure to check their serum creatinine a couple of weeks after you've started that therapy. If there's a greater than 25% increase, you really need to stop the ACE or ARB and send them for evaluation of renal artery stenosis. Effectively what they've done there is to fail what we used to call a captopril stimulation test. When you administer an ACE or an ARB for a patient, you knock out the kidney's intrinsic compensatory capacity to respond to changes in blood volume. And so if a patient has renal or artery stenosis and at baseline their kidneys are poorly perfused, you add on the ACE and you can see a really dramatic drop in filtration capacity and therefore a rise in serum creatinine. So anyway, if the rise in serum creatinine is less than 25%, it's fine to continue the ACE or ARB and then just continue to monitor. There has been contention over time in terms of how long the ACE or ARB should be continued. At this point, the thinking is that the patient should continue that until there is some sign of intolerance. So generally speaking, patients will tolerate an ACE or ARB pretty well into CKD4. Sometimes they run into trouble with hyperkalemia. Ideally, that can be managed with diet, but there's no absolute cutoff at which the patient should stop an ACE or ARB. And it's important to know in terms of patient education, proteinuria suppression is better achieved if the patients are adherent to a low sodium diet and are on a diuretic as well. And as we've discussed before, you really want to avoid volume depletion. So again, educate your patients. If the patient is on an ACE or ARB, just let them know. If you get a fever, if you have vomiting, nausea, diarrhea, gastroenteritis, any other sort of acute health issues, just stop the ACE or ARB. It's fine to let the blood pressure ride high for a little bit. Much better that than to be dehydrated and on an ACE or ARB and doing damage to the kidneys. So let's talk about blood pressure targets for chronic kidney disease. Essentially, there are a couple of key criteria in here. The first one is whether the patient has protein in the urine or not. That's really your sort of number one decision point when you're thinking about what target to manage to. So if the patient has any protein in the urine at all, you want to be managing to a target of under 130/80. If the patient doesn't have protein in the urine, then you're probably okay to manage to a target of under 140/90. So these guidelines come from two major agencies. One is bodies. One is the JNC, and the other is KDIGO. KDIGO guidelines are CKD specific. The JNC guidelines are not. It's the KDIGO recommendations that suggest less than 130/80 for CKD patients with protein in the urine. So the huge caveat here is that those guidelines, depending on which one we're talking about, say that they define these guidelines as applying only to patients under 60 or under 65. So anybody over that age threshold is described as elderly, and it's recommended that management targets be set individually. But when you think about the patients we're seeing with chronic kidney disease and diabetic kidney disease, for the most part it's an older population, so a substantial proportion of those do fall into that age range of over 60 or over 65. And I would say that it's incumbent upon providers to really think carefully about the patient's global health status, about their prognosis, and to tailor management strategies appropriately, to not manage overly aggressively. We do know that even elderly patients will have better CKD outcomes if we manage to this goal of 140/90. But those are longer-term risk modification strategies, meaning if I'm treating to this goal today, it's because I want this patient to have lower risk of CKD progression in 5 or 8 or 10 years. And if I'm seeing a patient who is unlikely to live for 5 or 8 or 10 years, then I haven't done them any favors because I'm exposing them to the near-term risk of more aggressive management of their blood pressure when they're very unlikely to realize the longer-term benefit of risk modification. So this is really where individualized provider decision-making comes in. And I would suggest that, historically we've used age as a criterion here, but I think that functional status is perhaps the more meaningful, or at least age in conjunction with functional status. There's more and more research out there to suggest that that's a more important indicator. So if you're looking at debilitated patients with a heavy load of comorbid illness, then you really would want to approach management differently than you would with a patient who is younger and has a higher functional status. I think it's pretty well known at this point that ACE and ARB shouldn't be administered in conjunction, either one or the other. Patients don't realize any benefit from being on both, and it does increase the risk for them, risk of adverse effects. I would say, generally speaking, in my practice, when I see patients who are on both an ACE and an ARB, it's not because any provider intended that. It's because these patients are complex. Oftentimes they're seeing multiple providers, including specialists. And so as a result, the patient may or may not have known that when they started one medicine, they were intended to have stopped another. And so it's just a reminder that we really need to be diligent in our oversight, medication reconciliations, and be educating our patients well. I'm going to move through this quickly. This is basically just demonstrating that you have better outcomes for both CKD progression and for proteinuria when you administer an ACE or ARB for patients with diabetic nephropathy. And you guys can download the slides, so if you'd like, you can take a look at this and digest it more later. But in the interest of moving through our presentation, I'm going to move on here. So let's talk about managing diabetes, what our goals are for our patients with diabetic kidney disease. We want to manage to a target hemoglobin A1C of about 7. And again, I would say that needs to be decided in the broader context of a patient's health picture. So patients who are older, limited life expectancy, you may not want to manage to such an aggressive target. As kidney function declines, one of the kidney functions that the kidneys perform in the body is to metabolize and excrete insulin. So as kidney function declines, what you see is that the patient's insulin, whether that be endogenous or exogenous, it stays on board for much longer, and so they need less medicine to manage their diabetes. So be alert that as CKD progresses, patients are more at risk for hypoglycemia, and you may need to titrate down their anti-hyperglycemics. So lipid disorders, I'm going to summarize this by saying that Management of diabetes and hypertension are more effective in both forestalling CKD progression and reducing cardiovascular complications than statin therapy, and that although we have a number of guidelines here, really they boil down to the fire and forget, treat with a statin or possibly a statin and co-agent. But that I'm going to show you on the next slide here, that we don't see as much risk reduction with the administration of a statin, and certainly if you look at the hard endpoints of CKD progression, overall mortality, we don't gain the sort of benefit from managing cholesterol that we do with some of our other CKD-specific interventions. And keeping in mind, this is specific to diabetic chronic kidney disease. If you're talking about other populations, that looks a little bit different. But in CKD, just the fire and forget, put them on a statin should be adequate. Vaccinations, our diabetic CKD patients should be getting their flu and pneumonia vaccinations. They should get Hep B when they get to a CKD stage 4. Most dialysis units require that a patient demonstrate immunity against hepatitis B in order to dialyze in that facility. So complications of chronic kidney disease, most of these become more overt in their manifestations when patients get into later stage CKD4 and CKD5. However, they take root much earlier in CKD3 and even prior to that. So the complications that we see most commonly have to do with fluid volume status, that can be overload or underload, acid-base imbalances, electrolyte dysregulation, high blood pressure, cardiac disease, cardiovascular disease, anemia, bone mineral metabolism disorders, and malnutrition. Malnutrition is most commonly a protein malnutrition, as patients have accumulation of metabolites that they're not able to clear renally. They tend to have a protein aversion, and so oftentimes by the time patients have arrived at a CKD late 4 or stage 5, their protein consumption is very limited, and so we'll start to see a reduction in serum albumin. Management of CKD stage 4 and 5. Generally speaking, these patients are seen by a nephrologist, but I did want to review some of the principles of management so that you have a sense of what may be happening in the co-management model. The kidneys produce erythropoietin, which stimulates the bone marrow to make red blood cells. So as the kidney function declines, patients will become anemic. They have lower red blood cell counts. That's treated with with ESA, erythropoietin. It can be Aranesp. There are a couple of other versions out there. The main take-home point here, I would say, is that the patient needs to have adequate iron stores for the ESA to be effective, and so that may take either oral or IV repletion. We also really want to avoid transfusion for potential transplant candidates. If a transfusion is absolutely necessary, it should be a leuko-reduced transfusion, meaning that a leukocyte filter is used. If a patient receives multiple transfusions, it can potentially preclude them from receiving transplant because it really changes their reactivity profile. And then it's important in terms of treating their bone mineral metabolism disorder that we supplement with vitamin D3. It's better tolerated in the 2,000 IU over-the-counter formulary than in the 50,000 IU per month. And then DEXA tests aren't particularly valuable in this population as they don't correspond well with fracture risk in CKD 3 to 5. Metabolic acidosis, a couple of compelling reasons to manage this in our CKD population. It's associated with slower CKD progression if we can keep their venous bicarbonate above 2, and it may also help to improve their functional status. So generally speaking, we'll treat with oral sodium bicarbonate tablets. It is baking soda, but a little bit complicated to describe dosing for patients if you just advise them to use over-the-counter baking soda, generally better tolerated in tablet form. Hyperkalemia, again, more common in the CKD stage 4 and 5. Usually first line is to advise patients in terms of reducing their dietary potassium. Oftentimes it can be managed that way. These patients should not be on NSAIDs anyway, but should they be taking NSAIDs, they certainly should stop. Rare that they would be on a potassium-sparing diuretic, but if they are, that should be stopped. Beta blockers and ACE inhibitors and ARBs are oftentimes the culprits when patients have high potassium, so those medications should either be reduced or stopped. A patient should avoid salt substitutes. Some of those are really high in potassium, and it can be helpful to add a loop or thiazide, particularly a loop diuretic, to reduce the levels of serum potassium. And then it's treated with laxatives if the patient has a critically high potassium. This is a brief summary of the referral for, of the management guidelines for diabetic chronic kidney disease. As we talked about, there should be, for all diabetic patients, an annual screening for the protein in the urine and a chem panel, essentially, which will allow you to look at their creatinine and their electrolytes. You'll see when they're at the CKD stage 3A that we should be checking biannually these lab panels, and plus a panel that will give you information on the bone mineral metabolism disorder. So that would be looking at their parathyroid hormone and phosphorus levels. We want to be treating with the vitamin D, vaccinate against Hep B, and then talk about dietary counseling with these patients. When the patient has progressed to stage CKD 3B, you want to accelerate the monitoring. So now you're looking at doing a lab panel every 3 months, again, checking GFR, proteinuria, looking at their chemistry panel, bone mineral metabolism disorder. And then when they're under 30, they should be seeing a nephrologist if they haven't had any indication prior to that. So one last slide here. I wanted to talk a little bit about special managements of the older adults. We have alluded to some of these principles, but we see a tremendous number of elderly CKD patients, and in fact, the average age of people starting dialysis now is a little over 65. And I would assume that in most of your clinical practices, you're seeing a number of elderly patients. They really demand an individualized approach to management, and so this requires bigger picture thinking about the patient's their health status, and frank discussion with patients and family about what their goals of care are, what their priorities, and thoughts about how we can best support that with medical care of the elderly adult. And I would just really encourage you all to think about not reflexively applying established guidelines to the elderly population. In many cases, they require modification. So these are a few additional online references that I wanted to, or informational sources that I wanted to refer you to. In addition to this, I'll mention that I'm working with the National Kidney Foundation on developing a chronic kidney disease application, a mobile app that would allow providers to input patient demographic data, just about 5 key pieces of information, and then it will generate a customized set of recommendations for management. So it's not quite finished. It should be up in the next 6 weeks or so, but that's available through the NKF website. That's called CKD Care. And with that, I'll go ahead and open it up for questions.
Wonderful. Thank you so much. Our first question asks, is microalbumin creatinine ratio more accurate for screening?
I'm not sure what the question is getting at. I would say that it's a very effective screening test, but it's intended both for screening and for evaluation. So even once you've established that a patient has proteinuria, you can use it on an ongoing basis to monitor the degree of proteinuria.
Okay. The next question, why don't the GFR equations account for BSA in the formula? It seems to make sense they would.
Yeah, I agree, and I would say that mostly has to do with the fact that labs, in order to report eGFR, would need that data. In most cases, they have the age, sex, and race of the patients available. That's oftentimes included in the demographics that comes through in a lab order. BSA is not necessarily, and so I think to facilitate reporting of GFR, that it's done in that standardized BSA method, but I do agree that it's definitely a flaw in the test, but it's something that we can account for, adjust for.
Okay, the next question asks, at what point or should an ACE or an ARB be stopped due to worsening CKD?
There isn't an absolute cutoff. It's when a patient becomes intolerant, and in almost all cases that has to do with high serum potassium. And so as CKD progresses, if a patient has a high serum potassium, one of the things that can be considered for potassium reduction is to either reduce or stop the ACE inhibitor. Oftentimes that can be addressed with either dietary management or adjustment of other medications such as beta blockers and addition of loop diuretics, but there's no absolute cutoff, and there really is demonstrable benefit to continuing ACE inhibitors or ARBs as long as possible in the CKD continuum.
Great. Can serum creatinine indicate kidney function in very early stages of kidney disease?
So serum creatinine is never a great indicator of kidney function. As we talked about, it's really the eGFR. So you would want to plug that into the CKD epi equation and then adjust for BSA if necessary. And generally speaking, serum creatinine is a late indicator. So, in the nephrology research world, there's a lot of work being done to identify an earlier and more accurate indicator of kidney damage. But right now, serum creatinine is the best that we have, and we improve the value of serum creatinine by utilizing it to estimate the GFR as opposed to just using the creatinine measurement directly.
Okay. To the point about better proteinuria suppression when on an ACE or an ARB plus a diuretic, does this hold true even with an eGFR below 25 milliliters per minute when we would typically consider the diuretic ineffective?
So that is a good question, and I would say at that point it's largely academic, and that to a great extent we're doing the best that we can. Do patients realize the same degree of benefits that they would with a higher GFR? No, but is it better than nothing? Probably yes.
Okay. What glucose agent do you recommend in patients that show initial signs of nephropathy?
I wouldn't say that there's a specific agent indicated for management of their diabetes. I think that the more important question is what hemoglobin A1C you would target, and so about 7 is what you would want to look at for management of diabetes. The modification of medication tends to come later in the CKD staging, so when patients are, certainly beyond CKD 3, when you're into CKD 4 or 5, you want to start thinking about some agents that shouldn't be used.
Thank you. Next question states, are the BP guidelines for CKD with microalbuminuria stated according to JNC 8?
No. So that's per KDIGO. JNC 8 doesn't actually recommend managing blood pressure to below 140/90 in any patient population. They were a little bit more conservative in their recommendations, and in part because they didn't their inclusion criteria for research data that drove their guidelines precluded use of some of the big data trials that have been conducted among CKD populations. And so the KDIGO guidelines, which are better tailored to CKD patient populations, they have different recommendations for management because they're based on a slightly different set of data than was included in the JNC 8 recommendations.
The next question asks, are you going to share the formula for adjusting GFR?
Oh, I'd recommend just using an online calculator, and the formula essentially, it's just a conversion. So you divide by 1.73 and multiply by whatever the true BSA is. But it's pretty easy to accomplish with any of the online calculators, and there's a link to one in the webinar.
One of our attendees asked, why hepatitis B vaccine?
Oh, that's a good question. The thinking is that the patients are at higher risk for bloodborne exposure when they're dialyzing in a dialysis unit because they're, of course, hemodialysis involves removal of blood from the vascular compartment. Although there are plenty of processes in place to prevent cross-contamination, it is considered to be a risk factor, and so patients it's recommended that they be vaccinated against hepatitis B before receiving dialysis in an outpatient dialysis unit.
Why is there a different GFR for African American and non-African Americans?
So I'm in a PhD program, and one of the things that I'm looking at is racial disparities. And as I'm sure most of you are familiar with, the use of race in medical research is a pretty hotly contested area. What I can tell you is sort of the traditional thinking about this, and I understand that there isn't consensus around it. But physiologically speaking, African Americans are thought to have a higher muscle mass sort of per pound than, or a higher proportion of muscle per unit of mass than other populations, and as a result, they're expected to have sort of per unit of mass a higher serum creatinine.
Next question asks about the role of SGLT2s and the safety of metformin in patients with chronic kidney disease.
I think it just depends upon the CKD staging. So earlier in CKD staging, those are both fine. Later, CKD3B, certainly you should be thinking about modifying their regimen and utilizing other agents.
Okay, the question at hand is, what can I expect blood sugar to do when a patient is on dialysis and insulin?
The dialysis therapy doesn't directly affect blood sugar. The more salient issue there is the fact that at that stage, kidneys are very ineffectual at metabolizing and excreting insulin. And so, as I had mentioned, both endogenous and exogenous insulin will stay in circulating and active for much, much longer. And so very frequently those patients are, those patients are more at risk for hypoglycemia than one might anticipate, or than they would have been at earlier stages in CKD. But there's no direct interaction between dialysis and blood sugar.